Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. As always, feel free to ask any questions that you may have in the chat box, and your questions will be addressed as we move along. Today, we are continuing on our Pulmonary and Critical Care Month, where we're going to be talking about the pulmonary physical exam today. So we're going to actually learn about some physical exam skills, and we'll watch a couple of videos on how to do these things. I learned this recently this semester in medical school, and I'm excited to teach it all to you. So we're going to start off with talking about the cardinal aspects of the pulmonary exam. Then we'll talk about what's normal and then what's pathological or abnormal findings because, we don't know what is abnormal without knowing what is normal first. And then we'll talk about three diseases: asthma, COPD, pneumothorax, and also pleural effusions. And then we'll apply it all in a couple of case studies using AMBOSS practice questions. So by the end of today's lecture, I really want you to be able to identify cardinal aspects of the pulmonary exam, just kind of understand the differences between normal and pathological findings, and then finally, just correlate these physical findings to specific disease processes. And in this example, we'll be just giving you a couple of examples that we learned in med school. So before we start off with the physical exam, remember that we have tools, right? As physicians, the first tool that usually comes to mind is the stethoscope. These are really the tools of our trade, right? We use these stethoscopes. You see them being worn by medical influencers. You see it sometimes being given out. I know at my white coat ceremony, we were actually gifted stethoscopes by our Medical Alumni Association. And I think it's very common practice across a lot of medical schools across the country, because we know that, when you see a stethoscope, you know that that person is usually in the healthcare field, whether they are a PA, an MD, a nurse practitioner, a nurse, etc. So again, these are the tools of a trade. And we usually use these stethoscopes for like cardio pulmonary exams. And yeah, I mean, you'll actually learn why it's like this. And we'll learn a little bit more about auscultation and what that's for. But there's another tool that we're using more and more often now, called POCUS, which stands for point of care ultrasound. And this is one of the coolest tools doctors use today, and med students as well. We actually have like a POCUS elective at our school, and many other people also take POCUS electives, and there's like core POCUS courses. So basically, lung ultrasound, or what we call like POCUS, like I said, it stands for point of care ultrasound. And unlike X-rays or CT scans, this is a small device called a butterfly probe, which uses sound waves to create pictures of your lungs in real time. And it's completely safe because there's no radiation involved. So basically how it works is the doctor uses a small device like a wand, you can say, called a probe. And this butterfly probe sends sound waves into your body. And when these waves bounce back, the machine creates an image on the screen showing what's happening inside your lungs. POCUS is very super portable, so doctors can use it right at the bedside, or even in an ambulance. And it's especially helpful in emergencies where speed is very critical because sometimes it takes time for an X-ray to happen. You need the patient to be still. And then, of course, X-rays come with their own um, uh, side effects sometimes as well. So instead of waiting for test results or an X-ray machine, you can quickly see what's wrong with the lungs using a point-of-care ultrasound device. So POCUS can actually tell us, for example, like if the lungs are healthy and filled with air, like an inflated balloon, like it should be, or collapsed, which might happen if there's a hole in the lung due to trauma or injury, or if the lung is full of fluid, like in cases of pneumonia or heart failure. So, imagine someone is coming to the ER and they can't breathe. Using this tool, a doctor could like immediately figure out if it's fluid in the lungs, if it's a collapsed lung, or something else entirely. It's like having X-ray vision without the harmful side effects. So it's a very helpful tool. I highly recommend you kind of learn a little bit more about it. And if your med school offers an elective like this, highly recommend because then you get to learn all the skills and what all this A line, B line stuff means. I know it all looks kind of the same and it's very hard to differentiate, but with practice and doing it over and over again, you're able to differentiate normal versus abnormal. So now let's talk about the cardinal aspects of the exam. So why is it called cardinal? That's what I was kind of confused. I didn't know what cardinal meant, but if you kind of think about it, remember cardinal directions or cardinal compass? We have four directions: north, west, east, and south. So I think that's sort of what they're getting at with inspection, palpation, percussion, and auscultation. So these are the primary core tenets of our physical exam. So we're going to be focusing on the lungs this time, right? So the first one is inspection. So this is the first step in a pulmonary physical exam, inspection. And inspection is all about what you can observe visually about the patient before using any tools like the stethoscope. So first, let's talk about assessing the patient's overall status. Like, what does the patient look like? Are they resting comfortably, or do they seem to be struggling to breathe? So if they're resting comfortably, this means that the patient looks calm, their breathing appears normal, and they aren't showing signs of distress. Extremis, you can see here, this patient is intubated. An extremis is when a patient is in severe respiratory distress. Often they're gasping for air, they're unable to speak properly, or they appear very tired or pale. And this signals a medical emergency. Like if you Google images, like this is the only image I could find about extremis, you wouldn't want to take a picture of an actual patient in extremis, but the best way to kind of symbolize is like a patient really needs that vent support, that air support. Another thing you could observe in a patient is if they're tripoding. And an example of it is here on the bottom right picture here and also here. This is when the patient is leaning forward with their hands on their knees. It's a classic position people adopt when they're trying to open their airways to breathe better because you're able to use more muscles in that way. And then supplemental oxygen. Like, is this patient on supplemental oxygen? Like here, you see this smiling, happy woman, but she is on supplemental oxygen. She's on nasal cannula oxygen. She might be, carrying a gas tank with her that we don't see in the photo. And here another woman is being placed on supplemental oxygen. So it could be either via mask or a nasal cannula, and that can indicate a pre-existing respiratory issue or that they're currently in distress. Next, we observe the chest. This involves checking for any visible abnormalities or asymmetries. So symmetry, right? You want to look at both sides of the chest. A symmetric chest expands evenly during breathing, and if one side isn't moving, it could indicate a problem like a collapsed lung. And I'll show you exactly how we actually palpate that and feel for that. This is like a CT I wanted to show you because here this is an uneven chest. You can see here now. Basically, CT scans, they're taken from the angle of if you're facing the patient from their feet, like if they're resting on a bed. So this is the angle that it's from. So, or imagine you're looking at the patient from, like, let's say you're super tall. Let's say you're 10 feet tall and you're looking at a 5 foot patient so you're basically kind of seeing through them from the head level, looking downwards, but actually it's from the feet up. So you can also look at trauma, scars, or any other deformities from, like, you also want to check for scars from any previous surgeries, like deformities like a caved in chest, that's called pectus excavatum, or signs of trauma like bruises or fractures. So, like, I just want you to all to, like, when you were all future providers, take a moment to think, like, if you were to walk into a room and see someone leaning forward and struggling to breathe, what might be your first step as a first responder. So inspection really gives you the first hints to act quickly and appropriately for your patient's best possible care. So here, this is a slide that shows examples of normal and abnormal chest shapes. So remember, I was kind of getting at, like, this is what the CT scan would look like. So this is normal, right, on the top left here. Basically, these differences can basically give you important clues about a patient's underlying condition. So let's start off with a barrel chest here on the second panel. This shape is common in diseases like COPD and emphysema, where the lungs stay overinflated. Then there's also kyphosis. Kyphosis is basically a forward curved spine that can limit lung expansion and make breathing difficult. There's also like I talked about before, pectus excavatum and pectus carinatum. So it's spelled carinatum. So these are Latin words. So these are structural chest deformities. The pectus excavatum, that creates a caved-in chest, like towards the inside, while pectus carinatum makes the chest kind of stick out. See this little sticking out shape here? And then there's scoliosis. Scoliosis is basically the sideways curvature of the spine, and that can cause uneven chest movement and also impair lung function because sometimes the body wants to compensate for that curved out spine. So that can cause an uneven chest shape. So Inspection is critical, right? Because it gives you the immediate clues to that patient's condition without any tools. You're just looking at them with your eyes. That's why we need to train our eyes and know what we should be looking for and what is normal. So, for example, like spotting asymmetry could lead you to suspect like a collapsed lung or pleural effusion, which is fluid around the lungs. We'll learn more about that later this lecture. And also observing tripoding might also just suggest like severe asthma or another condition that might be causing an airway obstruction. Now let's move on to something very important when inspecting a patient, their peripheral findings. This means looking for clues in areas like the fingers, the nails, and also around the mouth. That might tell us how well oxygen is getting to the body. So there is something called cyanosis. Remember, cyan means it's a shade of blue. So let's talk about cyanosis, which means a bluish color in the skin or mucous membranes. Cyanosis actually happens when there's not enough oxygen in the blood. There are two types. There's perioral cyanosis. This is like a bluish tint around the mouth. Often it's seen in babies or very, very, very sick patients. It's a sign that their oxygen levels are dangerously low and they may need immediate intervention. And then there's also digital cyanosis. Now, remember, the digits also refer to our fingers. So the digital cyanosis is often in the hands or fingers. You'll see like a bluish color in the skin, especially at the fingertips, as you can see here. This often happens when the circulation in extremities is poor, like in very cold environments or severe heart or lung disease. Now let's talk about clubbing. Not the partying, but actual nail clubbing. This is often when the tips of the fingers become swollen and the nails they tend to curve downward. So it's kind of like here, like you can see here, the nails are kind of curving downward, but they're also extending out. Basically, the best way to be able to check if a patient has clubbing is through this test called Shamroth sign. So you kind of put them together, your fingers together, and then you kind of try to touch both index fingers, nails in that position. And if you see a window called a Shamroth's window, then that means your nails are normal. You're not clubbing. And now you can do it on yourself, and you're probably fine unless you have an underlying lung condition. But if you do not see window, like if there is a contour like this, and and the fingers kind of touch each other like that, and there's no window, then that means that patient might have clubbing. So clubbing is often caused by chronic hypoxemia, which means low oxygen levels over a long period of time. You'll see it in conditions like chronic lung disease or heart defects. And then that symbol test, you basically have to, like I explained before, like you place the backs of your fingers together and then you look for a small, this diamond-shaped window between the nails. And in a patient with clubbing, the window disappears because the nails are curved way too much. So this is very clinically relevant because peripheral findings like cyanosis and clubbing, they're critical because they help us identify serious problems with oxygen delivery to the tissues. So for example, if you see cyanosis, it tells you to immediately check oxygen levels and think about conditions like pneumonia or heart failure. And if you notice clubbing, it's a sign of a chronic problem like cystic fibrosis or COPD that has been causing low oxygen levels for a long amount of time. So I just want to engage you all and just I want you to think about as you're listening, like if you saw someone with blue lips or a swollen curved nails, like what would be the first thing you'd want to check? These signs can be life-saving because they point to big problems before you even use any advanced tools. Like you'd want to check the respiratory rate, you'd want to check their pulse ox as well, to make sure that their oxygen levels are okay. Or you'd want to, of course, deliver them oxygen if they're not having enough oxygen delivered to them. Now let's move on to the next step of the physical exam, palpation. This is where basically we use our hands and tactile sense to feel the patient's chest to gather more information about what's happening on the inside. And the first thing we do let me see. The first thing we do is look for general signs that something might be wrong. So you can check for tenderness, like if the patient feels pain when you press on their chest, if it could point to a rib fracture or maybe a muscle injury, and also bruising, like bruises on the chest might indicate trauma, like a car accident or a fall, which could also affect the lungs, and also lymphadenopathy, which you can also feel for swollen lymph nodes, especially near the neck and also the armpits. And swollen nodes, they might suggest infections or even more serious conditions like cancer. And as for symmetry of expansion, we want to check how evenly the chest moves when the patient breathes. And we were talking about chest symmetry. A best way to check it is if you test the movements of the costal margins, you place your hands on the chest of the patient here like this in panel D, and you ask them to breathe in and out. That's how you're kind of also assessing for symmetry. So basically, when you place your hands, you would place them at the 10th rib space around the lower back as well here. And your thumb should point towards the spine in the center, this dashed green line, and your fingers should fan out around the sides. And so when you're thinking about like what to observe, when the patient takes a deep breath, your thumbs should move apart equally. And if one side lags or doesn't move, it might suggest a collapsed lung or something blocking the airflow. So that is a really easy way to check for chest symmetry. And I can actually show you here on this slide.
To assess chest expansion, there's two different ways of doing it. In the front of the chest, you're checking for outward expansion and also anteroposterior expansion. In the back, you just check for outward expansion, both at the top and the bottom. So for outward expansion, this is how you do it. You put your fingers on the skin on either side, drag into the middle, and keep your thumbs off the chest surface. And you ask them to take a deep breath in and out. And you're looking for the movement of both fingers, and they should move equally apart. That's outward expansion. If you want to do anteroposterior expansion, you just lay your two hands at the top of the chest, ask them to take a deep breath in and out. And you're looking for the upward movement, which should be equal on both sides. When I was checking expansion at the back, you may have noticed in the video that I was able to reach across and perform it in a similar manner to that which I did in the front of the chest. Quite a lot of the time you don't have space to do this, so you'll actually have to reach across and invert this arm and do it this way around. And I'll show it works just as well. So if I grab, move across, can you take a deep breath in? And out. Brilliant. Thank you.
So you can see here how the thumbs, they kind of moved apart and returned back, and that was done evenly so that patient has asymmetric chest expansion. Next, I'm going to talk about tactile fremitus. There's a video on the next slide about it, but let me just explain what that means. Basically, tactile fremitus is the vibration you feel in the chest when the patient speaks. So how to check this? You would basically place the palms or the edges of your hands on the patient's chest, and then you ask them to say 99. And the vibrations should feel the same on both sides. And what you'd find like in abnormal findings, like you would see decreased fremitus. Like if and decreased fremitus basically means if vibrations are weaker on one side, it might mean that there's fluid in the chest, like a pleural effusion, or an obstruction or air outside the lungs, like in a pneumothorax. And increased fremitus is if the vibrations feel stronger. It could mean that there's something solid inside the lung, like a consolidation from pneumonia. So palpation really gives us like these key clues as to what's happening inside the chest before we use any advanced imaging. This is much faster, much more efficient, and this is why we should be trained to be able to do these physical exam skills. For example, like a decreased chest expansion can immediately like alert us to a collapsed lung, while increased fremitus helps us suspect pneumonia. So here we're going to watch a video on tactile fremitus. There are two different ways to do this. So let's watch it and learn a little bit more.
Tactile fremitus. Tactile fremitus is a palpable vibration of the chest wall resulting from speech. Tactile fremitus may be performed in two ways. The first way is to place the ulnar surface of your hands against the patient's chest wall and ask them to repeat the phrase 99.
99, 99, 99, 99, 99, 99.
The second way is to place the palmar surface of the fingers against the chest wall and again have the patient repeat the phrase 99.
99, 99, 99, 99, 99.
The test should be repeated from the front, again going from top to bottom. Again, have your patient say 99.
99, 99, 99, 99, 99, 99, 99, 99, 99.
Tactile fremitus is increased by conditions that cause the lung to become more solid, such as consolidation, fluid, or a mass. Tactile fremitus is decreased by conditions that decrease the transmission of sound waves, such as increased fat, an air fluid level in the chest wall, or overexpansion of the lungs from emphysema.
All right, so we learned a little bit more about tactile fremitus. So think about it like this: like if you placed your hands on someone's back and only one side moved when they breathe, like what might that tell you? So that's why palpation is such an important part of figuring out what's wrong through tactile fremitus. Next, let's talk about percussion, which is like tapping on a drum, but instead we're tapping on the chest to figure out what's going on inside. Percussion helps us assess if the lungs are filled with air, fluid, or something solid. So let's start off with a deliberate examination. So when you do percussion, it's basically this methodological process where we compare sounds on both sides of the chest. So if we're going to check both sides at the same level, bilateral. We always check the same level on each side of the chest, like you saw in the tactile fremitus video, to make sure that they sound the same. This helps us find asymmetries, which could point to a problem on one side. And then you would evaluate for asymmetry. So if there's differences in sound between the two sides, that's a red flag, and it might mean that there's something abnormal, like fluid or air, where it shouldn't be. In a healthy lung, for normal percussion sounds, you will hear a resonant note, which means that the lungs are full of air. Think of it like the normal sound of a balloon filled with air when you tap on it. Like you're thinking of a normal balloon. When you tap on that balloon, you hear a sound. That's a normal sound. So you can kind of think about it in that way. As for abnormal percussion sounds, there are two main abnormal sounds we might hear during percussion. You could hear something hyperresonant, like a timpani. This is very hollow, like a drum-like sound, like hitting an empty box. It happens when there's too much air in the chest, like in a pneumothorax, also a collapsed lung, which we'll learn about in a few slides, or emphysema, or when there's blood in the chest cavity. You could think of it as sounding like a timpani drum in an orchestra. Another abnormal sound you could hear is a dull sound. A dull sound is like a tapping on a solid surface, like a table. This happens when something dense is in the lung, like fluid from a pleural effusion or a mass, or when part of the lung is filled with something solid, like in pneumonia. This is clinically relevant because percussion is so important and gives us a quick idea what might be happening inside the chest without needing any fancy tools. So for example, if one side of the chest sounds dull while the other side is resonant, we might suspect fluid buildup like in a pleural effusion. Or maybe if one side is hyperresonant, it could point to trapped air from a collapsed lung. So imagine you're tapping on a balloon versus a table. Like how different would they sound, right? Even if you haven't really percussed anything in the past, you're able to kind of imagine the difference between tapping on a balloon versus tapping on a table. That's exactly what we're kind of doing with percussion on a patient. And these differences in sound give us important clues about what's going on inside the lungs. Now let's talk about the fourth, I would say very important. This is really one of the most important parts. I mean, all of them are important, but like I say the best for last. Auscultation is also the most complicated, hence the busy slide. So this is when we use a stethoscope to listen to the patient's breath sounds and gather clues about how well their lungs are working. So this is, of course, the typical what we imagine when we go see the doctor, and the doctor's like, take a deep breath in and out, and they listen to us with their stethoscopes. So normal breath sounds. The normal breath sounds, they're called vesicular, bronchovesicular, bronchial, and tracheal, basically based on where you're hearing it. So the vesicular sounds, they're soft, low-pitched sounds heard over most of the lungs. They're normal and they indicate a healthy air environment. And also the inspiratory phase, basically the breathing in phase, should be longer than the expiratory phase or the breathing out phase. You can see here, vesicular, see the inspiratory phase is much longer than the expiratory phase in most lung spaces. And then there's bronchovesicular sounds. So again, these are four panels. All four of them are normal breath sounds. The bronchovesicular sounds, they're heard near the center of the chest in the first and second intercostal spaces. They're louder and higher pitched than the vesicular sounds, but they're still normal in these specific areas in which you're checking them. These are heard near, so near the first and second intercostal spaces here. And the inspiratory and expiratory phases are about equal in length, you can see. Now let's talk about the bronchial sounds. These are loud, high-pitched sounds normally heard over the sternum here. So see this in blue, this is the sternum. And here in green, this is where you hear bronchovesicular sounds, and in the vesicular sounds, you hear over the red regions. So in the blue regions here, these are where you'll hear bronchial sound, because remember the bronchus is here, or the windpipe bronchus. It leads into the lungs. So we learned that in our anatomy as a lecture before. So in bronchial sounds, the expiratory phase is a little longer than the inspiratory phase. Then there's tracheal sounds. These are the loudest and highest pitched sounds here. So remember the trachea, then bronchus. So there are two bronchi. So trachea is the windpipe. My apologies, I misspoke. So the tracheal sounds, they're the loudest and highest pitched sounds that are heard over the neck and the trachea. These are normal when listening in this region, but abnormal if they're heard elsewhere. So let's talk a little bit more about like abnormal breath sounds now. So abnormal breath sounds like crackles or rails. Crackles, they really, and we'll listen to a couple of them. Crackles sound like Velcro being pulled apart or bubbles popping. They're caused by fluid in the small airways or alveoli. So if there are fine crackles, they're soft and high-pitched. They're often heard in conditions like pulmonary fibrosis. And then there's coarse crackles that are louder and lower pitched. They're often heard in pneumonia or heart failure. Then there's wheezes. Wheezes are musical, high-pitched sounds that are caused by air squeezing through narrowed airways, like in asthma or in COPD. They're typically heard during the expiratory phase, but they can occur during inspiration as well. Rhonchi are snoring, low-pitched sounds that are caused by secretions or mucus blocking the larger airways. This is also part of inspection. If a patient has any secretions, I didn't go over that, but there's different colors of secretions like white, red, green, yellow, clear. So these secretions are also sometimes part of the inspection, and they can tell you if there's a bacterial, a viral infection going on, or something else. So again, bronchi, there are mucus blocking, there might be mucus blocking the larger airways, and they often clear after coughing. So there's also stridor and other abnormalities. Stridor is basically a high-pitched sound that's heard over the trachea, usually during inspiration or breathing in. It basically indicates a blockage in the upper airway, like a foreign body or laryngeal edema. There's also a pleural friction rub. This is basically a scratchy, high-frequency sound that's caused by inflamed pleural surfaces rubbing together, usually due to pleuritis or infection. Also muffled or absent sounds. If the breath sounds are muffled or absent, again, how do you know if it's a muffled or absent breath sound? After hearing a bunch of normal breath sounds, you'd be able to tell. So, if the breath sounds muffled or absent, it could indicate a serious problem like a pneumothorax, like a collapsed lung, pleural effusion, or severe airway obstruction. Now let's talk about transmitted sounds. These are really related to the physical exam. Of course, all of them are, but these are specifically basically maneuvers you can have patients do to be able to tell. So bronchophony is basically when you ask the patient to say 99, and if their voice sounds louder than normal, it could indicate lung consolidation like in pneumonia. Egophony, you basically have the patient say E. And if it sounds like A when you listen to the stethoscope, when you're auscultating, this is an abnormal finding and could mean fluid in or consolidation in the lungs. Like basically, you ask the patient to say E, and if it sounds like A while you're hearing it, you should be hearing E, right? But if it sounds like A, that's usually because there is that's abnormal finding, and that could mean like a consolidation or fluid in the lungs. There's also something called whispered pectoriloquy. Basically, this is when you ask the patient to whisper 99, you just like whisper, I'll do a louder, so 99, okay? And it's normally faint or inaudible, right? But if it becomes louder over an area, this suggests a consolidation as well. Now let's summarize a couple of these auscultation sounds. I talked about wheezes and rhonchi, but it's very hard to tell what it is without actually hearing it. So that's why I wanted you all to hear it.
James, I'm now going to listen to the chest. If you could just take some deep breaths in and out through your mouth.
So this is an example of normal breathing sound, and then we'll compare it to abnormal ones. here in the asthma COPD example during expiration. It can happen during inspiration, but usually classically you'll see that during expiration. See these crackles? These crackles really sounded like Velcro coming apart. Let me go back to that.
James, now
Here's the wheeze. Those are the crackles again. See, it really
James, I'm now
sounds
going to
like
listen to the
it
chest.
really does sound like Velcro coming apart in this one. All right, so that's all for that. Remember, of course, if you do auscultate yourself and you hear any of this, please consult a healthcare professional. This is all educational content, of course, right? This is the disclaimer that they also include, and also I'm also including as well. Now let's talk about some disease correlates. We're going to go over obstructive lung disease, pneumothorax, and also pleural effusion. We might not have time to go through consolidations and fibrosis, but we'll see. I do have the slides ready, but just for purposes of time, I'll at least go through the first three, and then we'll do a couple of case studies on those. All right, so let's talk about COPD, and basically it's important to just understand the two most common obstructive lung diseases, COPD and asthma. COPD, who knows what COPD stands for? Right. COPD basically stands for chronic obstructive pulmonary disease. So again, it's in the name obstructive. So COPD is basically a condition where the lungs and airways are damaged, often due to long-term smoking. It's progressive, and again, which means that it gets worse over time, and it causes obstruction to airflow, making it hard to exhale properly. And asthma, on the other hand, is an inflammatory disease of the airways. Unlike COPD, asthma is often reversible with treatment. There are triggers like allergens, exercise, or infections that can cause the airways to swell and produce mucus, making it harder to breathe. You or someone you may know in your family or a friend might have asthma, and you might have seen their inhalers. I have a couple of classmates who also have asthma. So on obstruction on expiration, basically both COPD and asthma cause obstruction to airflow, particularly during exhalation. So patients may feel like they can breathe air in, but they can't fully get it out. And also there's hyperinflation, like when the air can't escape properly, it gets trapped in the lungs, right? If you can't fully get out the air that you're breathing in, that air will not be able to escape properly, gets trapped in the lungs, which causes the lungs to expand. That's called hyperinflation. So that can lead to symptoms like a barrel-shaped chest that we talked about before. Again, I think that's from our inspection part of the lecture earlier today. So you can go back and review that that barrel-shaped chest, and I talked about how it does happen in cases of COPD with patients who have that chronic obstructive pulmonary disease. Now let's talk about the cardinal findings, like how to recognize the signs of obstructive lung diseases like COPD and asthma during a physical exam. So we'll go step by step through inspection, palpation, percussion, and auscultation. So when looking at the patient, you might notice pursed lip breathing, which helps patients force air out more effectively. And you might also see, like I said before, a barrel chest, which happens because the lungs are chronically overinflated. On palpation, you'll feel decreased fremitus. This is because the air trapping in the lungs reduces the vibrations that you would normally feel when the patient speaks and says the 99. Percussion often shows you hyperresonance. There's this drum-like sound that occurs because the lungs are full of extra air in hyperinflation. And finally, when you listen with a stethoscope during auscultation, you might hear abnormal breath sounds, including wheezing, like I said before, the high-pitched musical sound, especially at the end of expiration, rhonchi, like a snoring or that gurgling sound that's caused by mucus in the larger airways that's trapped, and also perhaps also absent breath sounds, because in severe cases, areas of the lung might not transmit any sound at all, like in pneumothorax or severe airway obstruction. So these findings can really help you differentiate between lung conditions and decide on the best course of action. For example, hyperresonance and wheezing might suggest asthma, while a barrel chest and absent breath sounds could point to advanced COPD. And see here in the pink puffer picture here, this patient is kind of tripoding, right? To kind of use their accessory muscles to help them breathe out. Now let's talk about pneumothorax. A pneumothorax happens when there's an abnormal collection of air in the pleural space, which is basically the area between the lungs and the chest wall. This air prevents the lungs from expanding properly. So under normal conditions, the pleural space only contains a very small amount of fluid to like kind of for lubrication, to reduce friction and between the lungs and the chest wall during breathing. And I'll ask you guys, which X-ray is normal and which one is abnormal? That's right. The normal one is on the left and the abnormal one's on the right. So on the left X-ray, you can see a normal lung with no extra air in the pleural space. You see these nice sharp edges on the left and right. That's kind of how I know like this is a normal chest X-ray. On the right, though, you see arrows that are pointing to a pneumothorax. Basically, this is the lung because of all this extra black air in the pleural space. And so there's no more room for the lungs to kind of breathe in and out. So here, these arrows are pointing to that pneumothorax, showing how the lung is collapsed while the surrounding air fills the pleural space. And you should notice how the sharp white line, in red, marks the edge of the collapsed lung, while the black space beyond it represents the air in the pleural space. All right, now let's talk about the cardinal findings for this one in a pneumothorax. So when you're examining a patient, you might notice ipsilateral hyperinflation. Ipsilateral means basically affected on the same side, where basically the affected side of the chest appears larger due to trapped air. And there may also be decreased movement of the affected side during breathing. On palpation, you'll find decreased fremitus on the side of the pneumothorax because the air blocks vibrations from reaching the chest wall. And in more severe cases, you might see something called a contralateral tracheal shift, where basically the trachea is sometimes gets pushed to the healthier side due to pressure from the pneumothorax. And on percussion, it could reveal like a hyperresonant sound on the affected side. This is due to the extra air, of course, in the pleural space. And when listening with a stethoscope during auscultation, you'll find decreased or absent breath sounds on the affected side, since the lung isn't expanding and air isn't moving through the airways. So on exam findings, let me see here. Yeah, on this X-ray, you can see this X-ray is showing hyperinflation of the affected side with increased spaces between the ribs. And the collapsed lung is visible as a sharp edge, and there is an increased black area of air in the pleural space. Oh, let me go back to the previous slide. I think that's what I wanted to mention here about that. Because on physical exam, the affected side will also show like reduced chest expansion during inspiration, which confirms that the lung is not inflating properly. So clinically, this is very relevant. It happens all the time. Pneumothorax, they tend to happen either spontaneously or they can actually be caused by trauma, medical procedures, or also sometimes underlying diseases like COPD. But in more severe cases, it can progress to something called tension pneumothorax, where pressure builds up and compresses the heart and other major vessels. And that's a life-threatening emergency. Because remember, the lungs are not isolated. The lungs are working in a beautiful system with the heart, right? In the center here, so imagine like a patient with sudden chest pain and comes in with shortness of breath. By combining the findings from your inspection, palpation, percussion, and also auscultation, you can quickly suspect a pneumothorax and take immediate action to save the patient's life. Now let's talk about our third disease for today before we get into our case studies, pleural effusion. Pleural effusion occurs when there is an abnormal collection of fluid in the pleural space, which is the thin area between the lungs and the chest wall. Normally, the space contains a tiny amount of fluid to reduce friction during breathing, but in pleural effusion, this fluid accumulates excessively. Common causes include infections like pneumonia, congestive heart failure, because that could cause fluid overload, cancer, and conditions like kidney or liver disease, which can lead to more fluid overload. This X-ray on the left shows a normal lung, like the one in before, with no extra fluid in the pleural space. But on the right, you can see the pleural effusion as this white area at the lung base. This fluid pushes the lung upward and reduces its ability to expand fully. So again, the same thing, let's do our cardinal findings and go one by one. So inspection. When you're examining the patient, you might notice that they appear uncomfortable or they have shortness of breath, especially if the effusion is large. And on palpation, you'll feel two things. You'll feel decreased chest movement on the affected side because the lung can't expand fully, as you saw here in this X-ray here. There's not enough room for the lung to do that because of the fluid kind of pushing against it. And you also observe decreased fremitus as the fluid, excuse me, in the pleural space blocks vibrations from reaching the chest wall. In some more severe cases, you could also observe something called a contralateral tracheal shift, where basically the trachea is pushed towards the opposite side because of pressure from the effusion. And then for percussion, you over the fluid-filled area, it will sound dull or flat, unlike the resonant sound of normal air-filled lung tissue. Like if you have let's say you have a balloon, and you're tapping on the balloon because it's full of air and filled in balloon, that's the normal sound, right? But if it becomes a water balloon and you're tapping on it, it sounds a little bit different. That is a dull or flat sound. And then when you're listening, when you're auscultating with your stethoscope, you'll notice decreased breath sounds over the affected area, of course, because the lung is not expanding in that region, since that fluid is blocking air movement. You might also hear a pleural rub, which sounds scratchy, and that indicates inflamed pleura rubbing together. You could also hear crackles, which could be present if the fluid is accompanied by infection or other lung abnormalities. So, this is clinically relevant, of course, because pleural effusions, they can vary in size and severity. And remember, patients might not just have one disease, they may have multiple. So if a patient comes in with a chronic heart failure, or some other kind of heart disease, they might have fluid overload. And excuse me, the cause of the fusion would need to be determined, right? And that might involve further tests like a thoracentesis, like removing some of the fluid for analysis, because if it's an infection, you'd want to treat the underlying infection. You want to kind of address the root cause of that, not just drain the fluid, of course, because you can also do that. So imagine like you may have a patient who suddenly feels like they can't breathe. And using these physical exam findings, like a dull percussion and decreased breath sounds, you can quickly suspect a pleural effusion and act to confirm that diagnosis through a chest X-ray. All right, now we're going to move on to case studies. So I think we have a couple. Let's see. So I'm going to read this out to you. A 64-year-old man comes to the office because of a productive cough, limited exercise tolerance, and fatigue. He reports that he is always short of breath after climbing up the flight of stairs to his apartment. He has a 15-year history of type 2 diabetes mellitus and a 20-year history of hypertension. Current medications include insulin, amlodipine, ramipril, and a fish oil supplement. He has smoked 1 pack of cigarettes daily for 45 years, temperature 98.9, pulse 83, blood pressure 133 over 80 millimeters of mercury. Pulse ox on room air shows O2 saturation of 96%. The pulmonary examination is shown. We'll listen to it. This is a lung auscultation. Which of the following is the most likely explanation of the patient's symptoms? So let's listen to the pulmonary examination before looking at the answer choices. Okay, so I did hear towards the end, I'll actually talk like the lung auscultation in this patient shows bilateral end expiratory wheezing. So remember I talked about how one disease has that end of expiration wheezing at the end. So here I've highlighted for you the key parts of this case. So this is a 64-year-old male who presents with a productive cough, shortness of breath, limited exercise tolerance, and also fatigue. The key findings include a long history of heavy smoking, 1 pack daily for 45 years, bilateral end expiratory wheezing on auscultation, and an O2 saturation of 96% on room air. So this patient's long history of smoking is critical here, 45 years, pack a day. It's the leading cause of chronic lung diseases like COPD. His productive cough and limited exercise tolerance are hallmark symptoms of chronic obstructive pulmonary disease or COPD. So, no, the other choices don't say COPD. So we need to continue on because this is a two-step problem. First, you need to diagnose, like know what disease this patient has, and then know that disease's specific symptoms associated with it. So on auscultation, we all heard that bilateral and expiratory wheezing at the end, at the lung bases. That indicates obstruction in the airways. And this points to lower airway diseases like asthma or COPD. And it's important to differentiate this from conditions like pneumothorax or pleural effusion, where breath sounds would be decreased or absent. And the breath sounds were not absent or decreased, we could hear them. So pulmonary function tests in COPD would also show like irreversible airflow limitation, something called a FEV1 over FVC ratio. We didn't talk about that in this lecture, but we talked about, I kind of hinted at it in like our previous pulmonary physiology lectures. But basically, we would have a reduced FEV1 over FVC ratio, even after a bronchodilator use. So you can also like look into that. It's a little bit out of scope for today, but that's just something I want you to have at the back of your minds, because it is definitely something very relevant when we do pulmonary function testing. So let's look at the answer choices now. Answer option A, the collapse of alveoli. So we didn't learn about this yet, but it's called atelectasis. Basically, atelectasis that causes dyspnea and decreased or absent breath sounds over the affected area, but it doesn't cause bilateral wheezing, so this is unlikely here. Option B, the accumulation of fluid in the pleural space, or I think this is talking about a pleural effusion. The pleural effusion would cause decreased breath sounds and dullness to percussion, but not wheezing. This is not supported by the findings, so we can cross that out. Option C, accumulation of fluid in the alveoli or a pulmonary edema. A pulmonary edema leads to crackles, not wheezing. And bilateral respiratory issues that are related to fluid overload, like usually due to heart failure, that's not consistent with this patient's smoking history. As you can also see here, this patient has hypertension, not necessarily, I don't see any heart failure medications. So they're just being treated for his high blood pressure. So that's kind of how I rule that out. And then finally, option D, well, let's see. I talked about option, okay. Okay, let's talk about option D. So entry of air into the pleural space, that is referring to a pneumothorax. And we talked about this, how a pneumothorax typically causes absent breath sounds on one side, hyperresonance on percussion, and sudden dyspnea, not the bilateral wheezing. So I kind of already told you guys that this is kind of obstructive. So the correct answer is actually E, obstruction of the lower airways, because the bilateral wheezing heard on auscultation suggests turbulence in those lower airways. And that is characteristic of asthma and also COPD. But in this case, it's COPD because it's combined with the patient's smoking history and the progressive nature of the symptoms. Remember, I talked about this as a progressive disease, and COPD is the most likely diagnosis. So the correct answer is E. The most likely diagnosis is COPD. Again, that stands for chronic obstructive lung disease caused by smoking. Because of the findings of bilateral wheezing, the chronic symptoms, and the smoking history that strongly support this diagnosis. So again, this case highlights the importance of that auscultation that really told us, kind of led us to the correct answer, helped us rule out the other answer choices. All right, let's not play the same one there. Okay, here's our next case. All right, let me read it all for you while you're reading it. A 62-year-old man comes to the Veterans Administration outpatient clinic because of worsening dyspnea, dry cough, and left-sided chest pain for the past 3 weeks. He has been feeling more fatigued than usual over the past 2 months. He has hypertension, chronic tinnitus, and osteoarthritis of both hips. He takes enalapril and ketorolac as needed. He smoked 1 pack of cigarettes daily for 38 years. Temperature 90.9 degrees Fahrenheit, pulse 78, blood pressure 141 over 85 millimeters of mercury. Pulse ox under room air shows O2 saturation of 98%. The pulmonary examination is shown. We'll listen to it when I finish reading the rest of the question. There is dullness to percussion over the left lung base. Which of the following is the most likely explanation for this patient's pulmonary findings? So let's listen to the lung auscultation here. So far, it's sounding normal. So in case that was hard to listen, basically I heard the same sound here, here, and here, but not here. Let's listen to this again. I hear very muffled or absent breath sounds here. So this shows unilateral decreased breath sounds or the left lung base. All right, so let me show you what I highlighted that I found important in the next slide here. So let's summarize this case after you got the chance to read. This is a 62-year-old male presenting with worsening dyspnea, a dry cough, and left-sided chest pain over the past 3 weeks. His smoking history includes a 30-pack-year smoking history, hypertension, also osteoarthritis. On examination, we see unilateral decreased breath sounds and dullness to percussion over the left lung base. The key question is, though, what's the most likely explanation for these pulmonary findings? So the key clinical findings in this case, number one, there is the long-term smoking history and progressive symptoms that raise concerns for chronic lung pathology, including malignancy or also complications like pleural effusion. So left-sided chest pain, fatigue, and dyspnea, they're usually suggesting like a localized process in the lung, especially since it's unilateral. And of course, we had that physical exam done, and there was dullness to percussion over the left lung base. That indicates something dense in the pleural space or lung, like maybe fluid or maybe a mass, maybe a consolidation. So we're not 100% sure yet, but let's continue. There's also, remember, the decreased breath sounds those further support the presence of fluid or reduced lung aeration on that side. So let's talk about all of our diseases here. So this is not a two-step problem. This is really just asking you what is the diagnosis. So this is called a differential diagnosis, or DDX. If you guys remember, differential diagnosis is like all the possible diseases it could be, and then we kind of rule out, and then kind of have like a top 3 and then finally a top 1 differential diagnosis to finally figure out what is going on with the patient. Because once you're able to properly and accurately diagnose a patient, only then are you able to treat them and make sure that they feel better. So option A, pneumothorax. Remember the pneumothorax that typically presents with a sudden onset of chest pain and dyspnea, and not in this case, it's been happening for the past 3 weeks. It does have unilateral decreased breath sounds, and it does also have hyperresonance on percussion due to air in a pleural space. But this patient's presentation is more like subacute. It's not like very acute because and the dullness to percussion would exclude the pneumothorax. So it can be pneumothorax in this case. Option B, pulmonary edema. Pulmonary edema, that generally presents bilaterally due to heart failure or volume overload. And that causes bilateral crackles on auscultation, not unilateral findings. And this is unlikely in this patient with localized symptoms and findings. And then as for option C, pleural effusion, that is the correct answer, but I'll explain why. Remember, I kind of hinted at why could there be decreased breath sounds? Usually it tends to be because of fluid or a mass, and we only really talked about the fluid or pleural effusion, because the fluid, when that collects in the pleural space, it causes dullness to percussion, check, we do have that here. Decreased breath sounds, check, that does happen here. Dyspnea and chest discomfort, specifically on the affected side, which is check, that's also valid here. So, so far this answer is looking good. And remember, the unilateral dullness and that decreased sounds, those fit perfectly with the pleural effusion. And in this patient, the 38-pack-year smoking history, that raises suspicion for like a malignant pleural effusion that could be secondary to lung cancer. So there needs to be further evaluation with imaging and also thoracentesis to double check to make sure that this is not like a malignancy because of that the high risk with the smoking history. So I'll show you all on the next slide here. Yep, the correct answer is pleural effusion as suggested by the combination of dullness to percussion and unilateral decreased breath sounds. D and E were kind of distractors for you all because pneumonia, there's not much indication for an infection, and the foreign body aspiration most likely and usually happens if a patient has like a nasal cannula, or and they don't, because on room air they have a 98% oxygen, so they would not be on nasal cannula oxygen. So or in the history it would probably say, oh, this patient might have had an aspiration, or it could hint you towards it. So the correct answer is pleural effusion, as suggested by the combination of dullness to percussion and also unilateral decreased breath sounds. And this case highlights the importance of connecting the clinical history, like smoking, and also the chronic symptoms, and especially the subacute nature of it, with the physical exam findings to identify the localized lung pathology. So I want to engage you all and ask you, like, what further tests would you order for this patient, to further analyze this patient? Like, you would want to analyze the fluid, right, for infection, cancer, or other causes. But the answer would likely be like a CT scan of the chest to assess the effusion and thoracentesis, right? Thoracentesis is basically a procedure where you take a needle and you kind of take that fluid out and analyze that fluid for infection, cancer, or anything else that might be causing it. So that I think that is the last case for today for time purposes. So I really appreciate you all tuning in. Feel free to ask questions. You know, you can email us as well. I know we do sometimes receive questions either via the comments or email at the email at learn@teleshine.com. On our teleshine.com website, we do respond very quickly. We do have a team addressing those emails, especially the medical directors. So if you'd like to take the quiz, the session quiz is now live on teleshine.com/certification. As always, you'll need a 70% or higher to pass and receive your certificate for attending today. And our next session will be on December, in the first week of December, actually. We're going to be taking a 2-week break for Thanksgiving and also a couple of exams I have coming up. And then we will be learning about the musculoskeletal system. So all of December will kind of be like a musculoskeletal system / skin dermatology, rheumatology month. So looking forward to tuning in December and kind of learning from you all, from your questions. And finally, we'll be learning about musculoskeletal system on our Pathway to Med Ed series. As always, thanks for tuning in and looking forward to seeing you at our next teleshadowing session. Take care, everyone. Bye-bye.